Welcome, everyone. This is Travis Tollefson. I'm moderating today on a session on orbital fractures, and we're excited to start off today with Dr. Michael Turner. Dr. Turner is Program Director of Oral Maxillofacial Surgery at Jacobi Medical Center. He's at Mount Sinai, and we're pleased to have him start today talking about the orbital examination in response to orbital trauma. Michael?
Okay. So hi, I'm Michael Turner. I'm the Chief of Oral Maxillofacial Surgery at Mount Sinai Hospital in New York, the middle of the epidemic going on, the pandemic. Anyway, today I'm going to be talking about the ophthalmologic and orbital evaluation. So I look at orbital fractures slightly differently. A lot of times we see our patients and we're thinking about the bones and how the content has changed and so on, but we really should be looking at the whole area in general. This is our disclosure information. So today what we are be talking about is we're going to look at doing an ophthalmologic evaluation and kind of understand, grossly what we're going to find and understand how this kind of ties in with the radiographic analysis. So I'm going to take this very relatively quickly about this. So, there's 7 bones: the maxilla, the zygomatic, the frontal bone, the ethmoid plate, and lacrimal bone, palatal bone, and so on. So the growth and development, you can see the orbit really doesn't change. It's about 30 cc's. And so once it's at a certain level of size, we're not looking at it's not going to be any different. So here's when I look at an orbit, here's what we should think about. The wall thickness on the outer area is very large and very hard, and the area in the medial and the floor is very thin. And that's very important because that's gonna protect the eye. So here, looking down from a bird's eye view, you can see, you can't really see the eye. The eye is inset inside of, kind of protected by that hard outer rim of the cavity. So if there's an impact in the area, the orbit doesn't get touched. But if the orbit is struck, it's going to affect the thinner bones. And the reason that occurs is if you look at the globe of the eye and looking from above, it's mostly spherical in shape. So when force, the kinetic energy, and so this is really just physics. So when kinetic energy hits the globe, it expands. It expands laterally and inferiorly, superiorly, and this kinetic energy is now within the globe. So if the inner surface of the floor and the lateral walls were very thick, that kinetic energy, that potential energy that is now inside of the globe, is going to rupture the globe. So the way to disperse that kinetic energy is basically, it needs to be transmitted somewhere. And this is the old ball toy where you drop that metal sphere, the other sphere on the opposite side is going to come out. The kinetic energy is transferred through those balls to the opposite side. And the same thing will happen. That kinetic energy goes up and it hits those thin walls and fractures those thin walls. And once it fractures those thin walls, it disperses the kinetic energy and the globes go back to a normal spherical location. And that's why the globes don't really rupture for most part. So, and we'll get to what happens when they are hit with more kinetic energy than the bones can displace. So the first thing I do whenever I see any type of orbital injury, I just open up a Snellen chart or any other letters and say, can you see this? Because that's going to be, I need to get a consult. I need to check out everything else. Oh, by the way, you do have to ask them if they could have seen it beforehand, because every once in a while you do have someone who is blind. The other thing to really look at, and this is actually not too hard to do, a lot of EDs have these Woods lamps in the ED proper. So you just put a little fluorescein dye in. It's just 1 or 2 drops if you can, And you turn on a Woods lamp, and there you see a corneal abrasion has occurred. Because if the globe is hit, you can easily get a corneal abrasion. And all this stuff is appropriate documentation. That's not going to really affect your care. But what is that when you do put in an ocular shield, this is one of the leading lawsuits that occurs in anesthesia and by nature into other people having corneal abrasions. So it's good to know ahead of time whether there was a corneal abrasion pre-existing prior to treatment. The other thing, and this is very important, and this is really hard to do unless you really know what you're looking for, and this is why you have to dilate the pupils up to look. But if there's a retinal detachment, that's a no-go. You can't treat the patient. And this is why almost every orbital fracture or ZMC with an orbital component, again, an ophthalmological examination, because you need to have a retinal detachment. When we say go, no go on the surgeries, if there's a fracture, we always think about how much of the bone was fractured, but really we need to say, is there an ocular problem? Patients, when they start to get retinal detachment, and when you ask them their history, they'll see electricity or lightning flashes within what they're seeing. And that should make you very suspicious for an injury. Of course, there's foreign bodies which you need to look at. These are actually pretty easy to flake out. You want to be careful, particularly if you're right on the iris, but you should remove these if you possibly can. You can leave them for later on, but they're going to cause a lot of inflammation, and it's going to necessitate a secondary procedure by the ophthalmologist, typically to remove it. So the lacrimal ducts as well, we're going to look at. Now, the concern is with drainage, you'll get a epiphora and really a lot of fluid coming out, but that's really hard to determine on patients immediately post-surgery, post-surgery and also post-injury. And that will necessitate a dacrocystolrhinostomy later on. But it's nice to know ahead of time if it's damaged. This can also take effect in your incision if you're for the approach to the orbital floor. So you kind of want to know what's going on in that area. Now here's what we really need to look at, and this is entrapment. And entrapment is what is a go surgery, a go portion. Once you see a patient with entrapment of this portion, the muscle is been trapped. Now, this is you really do have to go in earlier on this with the muscle trapped in those bony particles, and usually it's the inferior rectus muscle. You can start to get necrosis of that muscle, scarring of that muscle, and that will necessitate surgery later on. And even then, it's very difficult to correct. And it's usually performed by the oculoplastic surgeons. So you really want to prevent the necrosis of the maxilla. And if you see that entrapment, it's really, you have to do it. You can't really see it too well on the radiographs. It's really a clinical diagnosis. You can see the muscles lower, but you see this often. So it's the clinical examination which is really going to tip you off whether you need to do any procedures on this. So it's really one of the other clinical findings when you see this is when the patients look up and it's severely painful. It's not just the diplopia on upward gaze and non-movement, but it's very painful and it hurts. And it's a major concern in children because they get that ocular cardiac reflex and they'll start to develop bradycardia and arrhythmias. Once again, that needs to immediately go to surgery, and the anesthesiologist has to monitor that very carefully and increase the rhythm as needed. So when I look at something like this, this is the different story. This has got a very large opening, and I'm not so concerned about the muscle going down. And the reason I'm not that concerned about the muscle and the orbit going down is this. This is showing the muscles and the structures that are supporting the globe. And number 3 here is the Lockwood's ligament, and that's actually basically the support of the globe, which is not going to allow the globe to sag. This is very important, and generally it does not get detached, even on a bad injury. It gets detached on a large fractures of the whole complex, like a bad ZMC fracture, and you get detachment of Lockwood ligament, and that's when it drops down. And that, of course, needs to be, support needs to be reattached if necessary, or, you know, with your implant is really going to give a lot more support. But that's a very difficult thing to manage, and you do really have to pick up on it and seeing. So when you look at this MRI, you can see one of the globes is enlarged, and you can see Lockwood's ligament, and it's drooped down. It's not attached, and so this is going to necessitate a secondary surgery or a primary surgery. And a lot of times you do need to get an oculoplastic surgeon into play. Other things to look at is the pupil. Now we a lot of, you know, it's often that I look at a patient's history and physical, and it says the pupils are equal, round, and reactive. You really have to look at the pupils. Are the pupils round and reactive? This is not round, this is ovate. So we start to get concerned about an injury to the eye, and there's hyphema in there. So very important to look at the globe. Anytime that you have these injuries, like I said, it's go or no go on your surgery. Yeah, you have to kind of remember that these are the areas that where we're going to run into situations. And of course, the intraocular pressure. It's not that hard to have to be able to measure this pressure. What's going on is if the pressure is over 16, which is the typical mean, then that's starting to tell you the pressure is high. Now, say you're not, you can't measure, you don't have a tonometer with you, the globe will feel like rock hard because it's really having a lot of pressure on it. So if you have a high pressure, there's a possibility of a retrobulbar hematoma, particularly if you don't have a large fracture of the floor. If the whole orbital floor or the lateral floor is kind of blown out, it's unlikely to be a retrobulbar hematoma because the blood will be able to kind of flow into the sinus. But it really should be, you should really be cognizant of that fact. So what is a retrobulbar hematoma? Well, a retrobulbar hematoma, it's going to feel, it's very painful proptosis. The eye is going to be really forward. And this is a problem because the orbit is going to have a lot of tension on it. And once that tension starts to occur, you get a decrease in the field because you're getting a pressure against the retina. And when you get the pressure against the retina, you start to lose your visual acuity. And you need to take this seriously, and it needs to be treated very quickly. You get an afferent pupillar defect on the swinging flashlight test. One globe is dilated and it's not constricting as you go back and forth. So you get something that looks like this. The pupil is it's very dilated, and it's not really getting down when you shine light into it. You can see actually in that 3 o'clock position, you can see the light shining into it, and it's not moving, and you can see the globe is pushing out. that is a exophthalmos, and that needs to be treated, that proptosis. So going in there, now there's talk about a lot of different ways to do this. Lateral canthotomies are the ones that the ophthalmologists use a lot. It's not always effective, particularly to get the hematoma out. It does relieve the pressure, the globe pops out, and then we're left with repairing it. But but there are other different approaches to get into the orbital floor or the orbital roof, and these are the areas of the incisions you make, and you dissect under the globe and relieve the pressure. And it's an acute emergency. You have about 1 hour to treat the patient prior to starting to get injury to the visual and start to the retina, really, and start losing visual acuity. When they do talk about lateral canthotomy, and what I've seen in the past is because a lot of the time when we're called on this, this is occurring, the residents are looking at this, and if they do a lateral canthotomy, they're really getting only the more anterior portion of the canthus. So it really needs to go in, and this is why I was saying that the other approaches are a little bit better to get to the orbital floor and to get more posteriorly. To really treat this, you really need to detach the whole lateral canthal tendon to allow it to decrease the pressure on the globe. So an ophthalmos is another thing that we see, but we don't really document very well. So typically you see it if there's, it's greater than 3 millimeters, and it's caused by a volume increase in the orbital volume. So the globe kind of sits back in there. You can see this in this kid, his eyelid is kind of closed down. It's very visible, but this isn't what we normally see in our patients. Patients come in to the emergency room and they are now very swollen. You can see the globe. This guy has a bilateral injury, but you can see there's a lot of swelling in the area, and it's hard to assess just grossly when you're looking at the patient whether they have an ophthalmos, because the soft tissue is so swollen. So this is a Hertel's exophthalmometer. I keep this in the clinic, and the area that it's a little tricky to learn how to do initially, but it really does tell you where the globe is positioned in an anterior posterior position, and you really should be documenting this for completeness sake. I will tell you, regardless of my time with the residents, I have taught the residents yearly on how to do this, and it's still not being done on a regular basis. And it's just because this thing is a little tricky to do. You have to do it often to really get good reads. And the same person should be doing the pre-surgical examination and the post-surgical examination. So it's being placed in the exact same area. And it will give you a more accurate assessment of not only where the patient is pre-operatively, but how you did post-operatively in restoring the orbital volume. So let's just talk about some contraindications for going in. Severe ocular trauma. Now, I don't think I need to tell anyone, if you saw a globe of this nature, it's probably a ruptured globe. You're seeing hyphema or retinal detachment, any type of traumatic lesions of the optic nerve, other than like a retrobulbar hematoma, you have to delay surgery. And this is just something that we kind of all know about, but it's always keep that in the back of your mind. We can always go in later. Sometimes we don't even need to go in on this. Even with a greater than 50% fracture of the floor or the medial wall, you still don't necessarily need to treat the patient. We use that, oh, it's 50% rule to kind of jump in there to go, but there is a reason not to go. General patient condition, comorbidities from other trauma, or patients are very ill for other reasons, cardiac or for an endocrine reason. And this is the one, a relative contraindication, which does occur once or twice a year, where the contralateral side doesn't have vision. It's already blind, so this is the one eye. It is a known complication. It does occur that a patient will lose vision in the eye after repair of an orbital floor. Typically, it's a retraction injury, but it can be, it can occur, and with leaving the patient completely blind. Also, compression of the optic nerve. If a compression of the optic nerve is occurring, you need to get neuro-ophthalmology on board to prevent laceration of the nerve. This is a very bad injury that is being shown in this CAT scan. They immediately need to be treated. Typically, the neuro-ophthalmologist will come in and decompress the bone. If the bone shards are on the medial, they go in through the ethmoids and get it, and they do their best to get the bone fragments away. If there is a visual loss, you have to put immediately on high-dose steroids. And when I mean high-dose steroids, you give them 300 to 400 milligrams of Decadron, which seems insanely high, but it really does occur. They have some complications from it, but it's really it can save their vision. And so that is also really where we're going to go with this. Dr. Lettieri is going to show you some video on this forced duction, but forced duction should be done after every surgery. It's done in a couple of different ways, grabbing inferiorly to the iris, but you can also go lateral to the iris and move the globe in all different directions with a post-op CT. And then at the very end of all your surgery, can the patient still see? So treatment goals, diplopia and ophthalmia, consideration for treatment, and the take-home points. I'm going to end pretty quickly, but at this point, but look, if there's any visual loss, you have to figure out why before you do any treatment. If there's any retrobulbar hematoma, needs to be changed. Orbital content, you might be considering treating very quickly, and entrapment of the eye muscles. And indications also, severe fracture of the areas proven by imaging, disturbance in mobility, anophthalmos, severe anophthalmos, and exophthalmos, secondary blow-in fractures. So at this point, I will take some questions.
Great, thank you, Dr. Turner. It was a nice review, and one of our questions, and several of our questions, have been revolving around the indications for involving our ophthalmologic colleagues, that being not just our oculoplastic surgeons, but in some centers, ophthalmology coming in the evening to evaluate an acute fracture is not standard practice. It's a controversial topic, but I wouldn't mind to get your take on it and what your current practice is.
My current practice is always to get an ophthalmology consult, because the worst thing that you can do is miss a ocular injury. And now I understand what you're saying, the ophthalmologist, and if there are any ophthalmologic surgeons on here, whenever you say I don't mean offense, people take offense, and it probably means I'm going to say something offensive. But the way that we handle this is, there are trauma conferences, and there are trauma and there are trauma kind of standards. So if the ophthalmologists are on board ahead of time, if you bring in and make it a formal protocol that the ophthalmologic residents need to come in and evaluate these patients, you don't have as much problems, because now it's coming from higher up on the food chain.
Very good. Yeah, I think this is a very regionally specific. Some centers go one way or the other. Let me ask the second question here. Coming from the participants, and thank you all for being here, by the way. This is a vague thing for us to describe a significant orbital floor defect that requires an open reduction. Do you follow guidelines of 50% of the floor? Do you have guidelines that you follow, or is this, what is your consideration of a significant orbital floor defect that requires an ORIF?
Well, if once again, if there's an ophthalmia, if there's a lot of herniation of content into the sinus, that's when I will start to be a little bit more, or a lot more concerned about a late ophthalmia occurring because of scarring and fibrosis of that area. And then it needs to be managed and treated. I just don't go by, one standard, which in a lot of the textbooks is, oh, is there 50% fracture of the bone? You treat these fractures, even if it's a smaller fracture, depending on your clinical examination and what you're really looking at for the whole global examination, like we treat everything else. There is no one factor that drives you to do surgery on someone.
I appreciate that. Do you use preoperative and postoperative antibiotics on most of your orbital blowout fractures?
Yes and no. They typically
Now we're looking for some very direct, very simple answers here. Do you have an indication why you don't use it and why you do use it?
Well, in the hospital, it's all patients get preoperative antibiotics prior to surgery. So
Okay.
They would get it. If they were going to be having a delayed treatment, then no, I don't give them antibiotics. And post-surgically, I don't give them antibiotics.
Right. And I think there's a lot of centers in training that suggest we put them on to avoid acute sinusitis. And I would suggest that it's likely most people's practice to avoid antibiotics in most cases, unless there's a, quote, barnyard injury with severe contamination from a wound from a motor vehicle accident or other aspects that we'd want to prevent. Is that something you would agree with, Michael?
100%.
Okay. And there's a comment also made from one of our oculoplastics colleagues that we just want to remember that he's suggesting that lacrimal duct injuries, require silicone stenting. These probably should occur within the first 48 hours to prevent scarring. And so those would be an indication of why if you have a laceration through the nasolacrimal apparatus, that those require some more intense and early intervention.
Yes, great comment. And once again, another reason to get an ophthalmology consult prior to doing anything.
We have some great questions from the group, including some about medial rectus entrapment and such. And with our time, I will just say this once and for all, and that's that the orbital course, which we offer every year, this next coming year will be in Florida, gives an opportunity for you to sit in a room with 12 people to go over cases and to answer and look over questions where, as you notice, many of Dr. Turner's comments and answers here sometimes have different opinions from other people. And that's the case and needs to be discussed. And that's why it's so nice to be able to come and sit in group settings like we'll be having. I'd like to introduce Dr. Sal Lettieri. Sal is at Mayo Clinic in Phoenix, and he's the chief of plastic surgery at Maricopa Medical Center. He has a vast experience. And thank you so much, Dr. Turner, for your presentation today. And we'll come back to you with some further questions after Dr. Lettieri.
Great. Thank you for having me.
Thank you, Travis. I am going to share is my screen sharing? Yes.
I think we might be seeing, yes.
Nope.
Yes, I'm seeing it.
Yep.
Yes.
All right. Thank you very much, everybody. What I'm going to do with this portion of the webinar is just basically like you and I are sitting together in the operating room, and I'm just going to explain a few things and then show some videos as if we have the live patient before us. There's no financial relationships to disclose. And for those of you that want to get CME, there's some CME available signing us up. The learning objective would be accessing the floor, and this would be specifically through a fornix incision, exploring the floor, and recognizing the anatomy of the posterior shelf. There were a few questions that were asked about finding the posterior shelf and also whether to use a porous polyethylene or gel film. I'm going to specifically talk about today if it's a larger floor defect. For the smaller defects the size of a fingernail, usually you can rest something on top of that, such as porous polyethylene or gel film or absorbable plate of some type. But we're going to specifically look at the larger plates and then fixation of the plate and also assessing with the force duction test. As you already learned about the anatomy, it's thinner on the medial floor and on the medial wall, and it's thicker laterally. And that's going to be important with the dissections. This is a classic example of something that you'll see. The thicker bone that will be lateral to this. As you can see, this is the area where you would dissect. And then when you dissect posteriorly along the lateral aspect, you can then lift up this tissue. And this is a sagittal with both the cartoon rendering and also the same patient. This is that posterior shelf, which is a portion of the sphenoid bone, which is fortunately for us usually intact, and this is the inferior rim. This is the same thing that you're going to see, but this is the cartoon rendering. All these structures are easily manipulated superiorly in the acute and even subacute. Several weeks or months later, there's some scarring of this tissue to the infraorbital nerve, which makes it a little bit more difficult to dissect. But in the acute setting, this usually lifts up. And it's going to be from the inferior rim to the posterior shelf where you're going to rest the plate. Most of the incisions that everybody has looked at would be a subciliary incision or a subtarsal incision, or a mid-lid incision, or a rim incision. But we're going to look and then a trans-conjunctival incision. But what I'd like to look at specifically today would be a Fornix incision. Now, there are questions about whether or not get ophthalmology and about patients that have entrapment. So this is going to be something that you're going to get a phone call from the emergency department all the time. The patient that's being shown here, you will get a phone call. This patient, they're saying, is entrapped. And if you look at this patient, there's a limitation of movement in the upper direction. You can see the sclera on the patient's left, and the right eye is not moving. You will be at home and they're calling you and tell you to come emergently. Actually, this is the force duction test on that same patient. When I do a force duction test, I usually grab about 13 millimeters from the inferior limbus of the eye. This patient is not entrapped. And you say, well, the patient had limitation of movement, must be entrapped. Well, remember that when they're really big and really swollen, this is actually that patient. This patient cannot be entrapped because there's nothing to entrap. This is just limitation of movement secondary to herniation and quite a bit of edema. So this is entrapment. So this is a patient with a significant injury. Actually, you can see he had a lateral canthotomy. Look at that, it stops. Now, one thing I should tell you is that when you're grabbing this, don't release it. Okay, you just want to have a gentle, it should be, you'll feel the stop. This is entrapment. Oh, sorry. This is entrapment. And when you look at this, it stops. It's not secondary to edema. Most of the time you have the opposite side, and you can compare it to the opposite side. This is the opposite side, and this will show that the eye moves. So I grab again, the inferior rectus fits or inserts at about 13 millimeters. Okay. So this is the patient we're going to show here today. So this patient has a left floor fracture and a medial wall fracture, and this looks just like that cartoon rendering from earlier. We are going to do a Fornix incision. Now, it's interesting about the Fornix incision, it's a direct shot. I use it for patients that it's an isolated orbital floor fracture repair. I do not use it when I'm combined for, this is my personal opinion, I do not use it when combining with significant mid-face fractures and other injuries, because it's hard to get the retraction of the lower eyelid to get around to the inferior rim. And there's a tendency for tearing of the lower eyelid and ripping it. You can connect this with a lateral canthotomy to be able to get a little bit more exposure. But for today, for these purposes, I'm just going to concentrate on showing you the fornix incision for an orbital floor fracture. Once you get comfortable with this, you can then extend your treatment, but just get comfortable with it. There are the structures that are cut through, as you can see here, would be the inferior tarsal muscle and the portion of the capsulopalpebral fascia. The inferior tarsal muscle is a continuation from the inferior rectus muscle. It doesn't have its own innervation, but what happens is that when the inferior rectus muscle pulls down, or when you're looking inferiorly, when this goes in this direction, it actually pulls the lower eyelid down a little bit. When you cut through that, it'll actually scar back later on, and it usually does pretty well. It's not as bad. So this is the patient that I just shown the and we're going to show exploration of the floor. I first put in a braided nylon suture. Braided nylon suture, there's different brands, and then when you put those in, I just put a couple in to help with the retraction. It also helps with the frost suture that I generally do at the end. Put in a Damar retractor, and I use a malleable for the inferior. And you can use a tongue blade also, but I generally use a malleable for this, or a tongue blade. I don't put a corneal protector in for this part. Actually, the inferior conjunctiva for me acts as a corneal protector. The commercial corneal protectors that are available are very thick, and it makes it tougher to do this. So if you have a very thin corneal protector, that's okay. But I'll go in with the Damar retractor, and then pushing down the malleable is actually pushing against the inferior rim. And then I will mark that right on top of the bone. So it's in essence directly on top of the arcus marginalis, and I'm palpating it with the cautery. This is a hollow tungsten tip cautery to use. You could use a knife with scissors for this. I use the cutting initially and then convert. And then what we're doing is these structures that we're cutting through are the inferior tarsal muscle and also a portion of the capsulopalpebral fascia.
And Sal, how low of a setting do you use on your cautery?
So whenever I use this, it depends on your thing. I usually just start at 10 or 12. So one thing, that's a good question. One thing you should remember is anytime that you grab that thing, it should be like a knee-jerk response. You ask about the setting. Thank you, Travis, because what you don't want is to have the normal blade setting of 30, because you'll really destroy the tissue. So I use a very low setting for that. This is now my corneal protector. So I put in a couple more sutures here that help reflect the conjunctiva. And if you look here at the muscles, you can actually see these are the lower eyelid retractors that have been transected, and then we'll reflect those, and then we'll replace the Damar in holding everything superiorly. And then once we've done this, it's actually a straight shot to get down to the floor. Once again, because of the anatomy of the bone and the anatomy of the injuries, almost all the time, unless there's a penetrating injury or a gunshot, the standard injuries are such that the lateral bone over the sphenoid will be non-fractured, and then the dissection carries out lateral. And then what happens is you're able to reflect the fat and the muscle that's in the hole. Use the doggy paddle method. This is what we call doggy paddle method of the malleables going back and forth. Suction and irrigate, suction and irrigate. If it's wet, you can pack it and then come back. I generally don't use the commercial anticoagulants because they tend to swell a bit. If you do put something in, you need to take it out. This is the dissection going all the way now to the back. We're going to go all the way lateral and then reflect medial and then have all the contents reduced. when I do this doggy paddle technique, I can actually hold the second malleable with one malleable, so I can do it with one hand. Ian Jackson actually used to have a spoon for this that he had sterilized, just a kitchen spoon. And he had the tablespoon and a teaspoon, but we can't do stuff like that anymore. That was some 30 plus years ago. So this is, and that would be certainly off label. So now what I do is once I've found the posterior shelf, I'll pack, what's it?
Oh, sorry, Sal. So could you comment on, let's say you're dissecting back doing that technique and you're having bleeding. Have you used preoperative injection with epinephrine, and do you use anything intraoperatively for hemostasis?
So for the eyelid, 1% lidocaine with 1 to 100,000 epinephrine. I do not inject the floor. For the hemostasis, I have found irrigating and sucking control, actually with cold saline will actually stop most of the bleeding. If I do see a little bleeder, I'll touch it with that tungsten tip cautery or with the bipolar, but most of the time just packing it will be fine. As far as things like you know, a commercial brand Flow Seal, I generally don't use that, but if it's a real bad injury, I will use it. But you make sure you have to suck all that stuff out because that will expand. So you never want to leave that in. But most of the time, packing will take care of it. If for whatever reason the patient's anticoagulate or something like that, I'll just leave it packed and then come back 15 minutes later, because you'd rather wait a little bit than take care of somebody with bleeding. But most of the time, it'll stop. Did that answer? Any other questions on that?
The only thing I was wondering is if you've had any situations where you've used a hemostatic pledget with something on it that might have caused some pupillary changes, or ever had that experience where you didn't like using something like that.
That's correct. And actually, that's one of the reasons I don't do the block and, you know, don't put epinephrine in the back. I'm just, you know, you probably can. I don't. I have never used, I don't generally use pledgets in the back. The only thing I will use sometimes is Flow Seal, but then I suction it out. I tend to use packing, and then it's not too much pressure, but I tend to use packing. If it's so bad that it's bleeding and it won't stop, you know, worst case scenario, I've never done it, but worst case scenario would be just to leave it packed and then come back later. But I've never done that. But if you're in that situation, then that's what you do, because you don't want to have continued bleeding in the back. But most of the time, some patients with packing will stop it. And usually after you've done that, you can see something and then bipolar it or touch it with the tungsten tip cautery.
Thank you.
So here's the dissection. And then now, usually you can measure with, usually it's like 23, 24, 25. Some people think 33 millimeters, but you can use your retractor and then gauge where you want to go. As far as the length, with this one, we're cutting off the medial wing. And there's a couple of little pearls here. So I tend not to use the little foot plate tabs for an isolated orbital floor. This is an anatomic plate. There are different commercial brands available. I'm not promoting any one of them. And then what I have discovered is that I will bend the back just a little bit. Because what I found is, despite the fact of sitting on the posterior shelf, that it actually sticks up a little bit. It looks like it's sticking in the inferior rectus muscle. So if you look at this, I will do just a touch of a bend in the back, and that's what I'm demonstrating here, right there. Oh. Sorry. So that's what I'm demonstrating here, is just a touch of a bend, and that'll rest on the posterior shelf very nicely. And then go back, do the doggy paddle, reduce everything, look at the posterior shelf, and I actually have an endoscopic shot here I'm going to show you in just a moment. And then once you've done that, have all the fat reduced. And then this plate, when you put it in, should just rest. You should not feel any resistance. You should have everything reduced. And then when you lay the plate in, it should just pop in without any, you shouldn't have to push anything. In fact, they should just rest right behind the inferior rim, and you'll see what I mean here. So we'll take the plate, it's just going to rest in. There's no pushing on anything. It just drops into the hole. And then you let go, and then just push down a little bit behind the rim, and then put a couple of screws in. And then once you do the screws, there's always a discussion about repairing the conjunctiva. I repair it because what we've done is we've disrupted the entire floor. It just takes about 3 or 4 sutures. I use a 7/0 polygalactin suture to place into the conjunctiva, because sometimes what happens is you have fat that'll herniate out and it'll granulate over. So I go ahead and repair it. The last thing you do is actually re-drape all the fat and for the orbital floor on top of the plate. And then here's the repair. Just use a caster, just to put just like 3 or 4 stitches. It's not a watertight. All it is sort of to coerce the conjunctiva to sit against each other to prevent the fat from herniating. And then at the very end, I will go ahead and do a frost suture.
Sal, could you comment on, so it's a nice endoscopic view there of the posterior shelf. Do you use any techniques to measure from the shelf to the orbital rim to help determine the length of the implant that you will use?
Yeah, so what I do is I'll take a freer elevator and or something, and then whatever measuring stick that you have, and then I will rest it on the posterior shelf with the vision. The freer, some of them have measuring or have a ruler on them, and then I use that dimension and use that to gauge my plate. If you're a little young in doing this, you can take some foil packet for the suture, and then you can rest that, but use it as a template, or you could use a template for it.
Yeah.
But I usually measure that distance, and it's different for the, everybody talks about the lengths, 33 millimeters, 25 millimeters, but really it's how you're going to rest the plate. Are you going to rest the plate over the inferior rim or behind the inferior rim? So I just put what I'll do is I'll take my thumb and then rest it on the inferior, with the freer, and then rest it to the posterior shelf, and then I'll use that as my measuring stick for the plate. But it's very important to have all this structure reduced when you rest it. So this is actually the posterior shelf. That's what it looks like. And then this is the plate sitting on top of the posterior shelf. And then this is what it looks like post-op. And then remember I was saying that I do a little bend. I've had this thing stick straight up a little bit, which I haven't liked. So now from now on, what I do is I just do a little bend, and it actually cups around the posterior shelf very nicely. This is a different patient. I did the medial wall repair with the retrocaruncle combined, but this shows how the plate lays in position. So the take-home points for this would be that the trans-conjunctival incision is an easy access to an orbital floor, an isolated orbital floor. The dissection of the orbital floor should start laterally where the bone is thickest and usually not fractured. The posterior shelf is actually the posterior most point of the dissection. You don't want to go any further. And it's a shelf that you need to rest the plate. There were a couple of questions earlier again about using porous polyethylene or gel film or some resorbable things. I tend to use those when it's a hole, and you really don't have to go by the posterior shelf, and you can just rest it on top. But when you have a very large fracture, you need something in the back against which that the plate can rest. So as a cantilever, stop, if you will. Closure of the conjunctiva is simple and prevents herniation of the contents. I've seen complications when people have not closed it, and the fat herniates and it granulates. And force duction tests should be always done at the beginning and always done at the end to make sure that you haven't done anything untoward. So we'll stop here. A link of this will be available. I'm going to stop sharing.
Dr. Lettieri, thank you so much. There's a barrage of good questions because of the nice content. One of the main ones there was that you mentioned using screws to fixate the plate. And as we know, in everything, there's always 2 sides to every story. Some people have found that if they use screws in the orbital rim or to stabilize the plate, that they may create a vector, a fulcrum, I'm sorry, that then rotates the shelf, the plate posteriorly off of the posterior shelf, creating a volume change. And
Okay.
so
Are you
how
able
do
to
you
see,
justify
are you able to see me?
Yes.
Okay. So if you notice what I did, if you take the plate and you rest it and you put the screws on the inferior rim, there's a tendency for the plate to move up. If you notice what I did, the screws went actually posterior. So it actually, there's a tendency for that to push the plate down. So that's the difference for this. So if you put the screws on the other side, the question, and so what happens is when you put it out here, so this is anterior, this is posterior. When you put the screws here, and what happens is this. But if you notice what I did was I cut off the foot plates and I put the screws to where they're fitting back here.
Such an important
point. Push down.
Such a very good point, Sal, because if you put the screws on the anterior face of the maxilla onto the orbital rim, you can create a change of position. So then the next questions, there was a series of questions about, you know, at our institution, personally, we do use intraoperative CT for each orbital floor just to confirm position and placement and also to get measurements of the orbital reduction. When would you use an intraoperative or postoperative CT scan on an orbital floor fracture, Dr. Lettieri?
So I get a post-op CT on all patients. We do not have intraoperative CT at the county hospital. We do at Mayo. I find that if you're concerned about it, you can just get the endoscope and take a look with the endoscope. As far as having everything appropriately reduced, that occurs at the operation. You have to really get everything lifted up and look at it in direct vision. I mean, that doesn't mean I've had 100% success rate by no means. The anatomic plates tend to have the little posterior bulge in it that goes behind the orbit, and that tends to help. But if you just rest the plate in with usually an anatomic plate, even if it's a flat plate, don't overthink yourself. Just if you rest the plate in with that posterior bulge and you visualize it on the back shelf, you should be okay. I completely think that if you have intraoperative CT, sure, go ahead. But not everybody has intraoperative CT. But I do get a post-op CT on everybody. That's why, by the way, I've noticed posteriorly when you have that posterior shelf, when it's resting there, I do the little bend in the plate so it rests. Because if you notice, the posterior shelf is not like this. It's actually a little bit like this. So the plate sits like this. I've had that. So that's why I do the little bend and it rests like that.
That's such a good point. And you know, the problem is if you think about the orthopedic surgeons and the fractures and the using of a C-arm, you can't think of an orthopedic trauma case where they wouldn't use intraop CT to assure that they have positioning of the fractures into the right location. There is a cost and there is a time for it. And as you said, you do look afterward with a post-op CT so that if there's anything you see you don't like, you could take it back.
Yeah, and every once in a while, I'll take it back. But when I say every once in a while, I mean like once every other year, I've taken stuff back.
Yeah. So then the next questions revolve around resorbable implants instead of titanium plates. I think I know how you feel about it. And the other, they want to know whether or not you would ever choose to use those. And then if you've ever used something where you use MedPore or porous polyethylene on the titanium. You've commented on that a little bit, but the difference between resorbables and MedPore is the inflammatory response. So what's your take on that, Dr. Lettieri?
Well, I could give a whole other lecture on this. So number one, on children, my tendency is to use bone. I have no problem taking a spilcarrial bone graft on a child and putting it in a child. Somebody who's going to be alive for another 60 to 70 years. So I'll use bone. The patients that have panfacial trauma, I tend to use bone because I'm usually harvesting bone anyway. The porous polyethylene with the titanium in it is just fine. You could use that instead of what I was showing. My intent wasn't to go over the difference in materials. It was to go over how to do it. But the technique I showed, you can use the porous polyethylene with the titanium, the hybrid plate, no problem. You could do that. What you cannot do is an isolated porous polyethylene without the titanium in it, because what happens is when porous polyethylene gets in the body, it'll tend to sag when it gets warm. So if you have a large floor like the one I showed, while it may look like it fits in there nicely, it'll tend to sag unless you have a thicker plate, and usually or mesh. And usually the meshes are not too thick because you get too much bulkiness with it. So the commercial sizes are 0.85 and 1.5, and then it goes up. Then it's much thicker from there. So I tend to use the 1.5 millimeter porous polyethylene, but that's just if there's a hole. You know how I describe it? If the hole is like a manhole, and I want to put a piece of plywood on it, so it'll rest around all the sides. That's when you can use an absorbable mesh. You can use the porous polyethylene. Those are the times I just rest something on there. But if it needs a bridge to hold it up, then I need something with a little more structure, and that would be the titanium floor plate or the hybrid porous polyethylene titanium plate, or a bone graft, a cantilevered bone graft that I can rest in there. Does that help?
It does. The regionally specific differences in the use of orbital floor implant materials is broad, and around the world it ranges from Calvera bone grafts to ear cartilage grafts to septal cartilage, from gel film to nylon sheeting, to titanium to porous polyethylene. There are a variety of resorbable implants now available. And there's some nice publications suggesting that's ability. However, I think in general, what I'm hearing from you, Sal, is if it's a younger person, you'd use a Calvera bone graft to minimize changes in their growth. In general, you use titanium because it's stable, and you find that it's able to be secured into place and not change shape. You haven't been using resorbable implants. You would prefer to use their own bone.
I have used resorbable for the small ones. For small injuries, I'm not opposed to it, because that heals with scar tissue and holds everything up.
And maybe that might be a case in a medial wall where you have a trapdoor fracture. You pop the bone back into place and you put a piece of gel foam or resorbable into that space, knowing that you can create scarring and maintain the orbital volume.
Yes, something along those lines. By the way, you made a point about nylon. I will go out on a limb and say that I've only seen complications when they extrude because they get a capsule around it. So I realize that there may still be people in the world, but I'm not going to advocate that. Everything else you said is fine, but as far as using a nylon sheet or a wrapped nylon or silicone, which has been used in the past, I've seen a lot of complications, and there's so many other things that are available. I would recommend using other things.
And I'm glad you made that comment. The only time I've seen silicone is in the half a dozen times I've taken it out during abscesses. And I certainly practice patterns around the world and around this country make it so that different surgeons are trained in different ways. And all we care about is that you're having the least amount of complications. And generally, silicone sheeting has been the one that I've seen complications from. And Dr. Lettieri is commenting on super mid or nylon sheeting also having some of those potential complications. We have such a great response here with questions. I'm going to try to pick one final one. Dr. Turner and Lettieri, thank you so much for your efforts today. I think this is a very interesting question that I'd like to have an answer from both of you. And that is, how often when you're dissecting in the floor do you need to sacrifice or sever the inferior orbital fissure contents to engage a solid lateral bone in high energy injuries to allow for you to have a lateral shelf to put your implant on? Is this something you do 1% of the time, 10% of the time, 50% of the time, or never?
I don't.
Okay.
I don't. I have, but I try not to.
Very good. I think if there's a crushed fracture and you need better access to get to the posterior shelf, but Dr. Lettieri today used the endoscope, which is a nice way to be able to see the posterior shelf. And I think to summarize what we saw today is that everyone would love to have an ophthalmologic evaluation prior to orbital floor fracture repair to document, but you need to have the best knowledge of what you're calling your ophthalmology colleagues with. Knowing what their vision is, from a simple, can they read your name ID badge? Knowing if they have red light vision, if they're having ocular pressure that's significantly increased, there's no time for an ophthalmology consult. Those are the ones where you want to do lateral canthotomy, cantholysis. If it's high energy explosion that they're involved in and they have commotio retinae or retinal detachment, these are eyes that you don't want to be dissecting into a ruptured globe. So then going through the dissection shown by Dr. Lettieri here shows how to protect from intropion and other injuries by using a direct approach down to the orbital rim. Certainly, use of other techniques to get to the fracture are very effective and have shown great results. We're not advocating for one over the other. As we close here, any final comments, Dr. Turner?
I just think that, you know, what I was just going to go back to a little bit, Dr. Lettieri, is, you know, there are so many different materials to use on the floors for implants. So it really is dependent upon your clinical comfort as well as the clinical scenario. So there isn't really one good answer for it.
It's a really good idea to get opinions from people you know and trust, and know that you can get away with putting in a small implant of any kind, especially in those fractures that wouldn't have necessarily needed repair anyway. And so these are the tough decisions we make, is if we're going to operate, what should we use? Dr. Lettieri, any final comments?
Oh, sure. And I appreciate everything that you said. One thing I want to let you know is I do all the incisions for the lower eyelid, and the whole intent here was just to show you specifically how to do a Fornix incision if you should decide to do it. I can do, you know, I can show you videos of other incisions. That's number one. Number two, I only showed the titanium just because that's what I had. You have to remember the principles. The principle is that you want to choose something that will stay where you put it. It won't sag and won't extrude later on. And you can decide what, I mean, those are solid principles, and you can decide which material you want to use for that. So, I just wanted to like give you an idea of not to fear the exploration of the floor and where to put the plates.
I think something that I wanted to repeat what he just said is that he does use all different approaches to the orbit, not just one. And getting that skill set and having that ability can help you in situations where you have reasons why you would need to use an exterior approach if you have lacerations, or if you already have an intraorbital conjunctival injury, you wouldn't want to recreate incisions that you don't need to. So having that skill set is probably a priority. There's questions about pediatric entrapment cases. Good news, next week we're going to be concentrating on pediatric fractures and how they differ. And so if you join us back next week, we'll be really happy to talk more about those aspects. And then some of the technical questions that are being asked, Dr. Lettieri and I will answer through the question and answer session. And we really appreciate all your time today.
Thank you very much. Thank you, Travis. Thank you, Michael.
Thank you all as well.